who is a palliative care physician at Pallium India Trivandrum, with main interest on community-based palliative care and pediatric palliative care. Warm welcome. You've already given us a very elaborate view on GI symptoms, nausea and vomiting. We are expecting another extended review on constipation too. A warm welcome to you, Dr. Sangeetha Suresh.
Thank you, ma'am.
Welcome.
So good to see you everyone back again. As ma'am said, we have completed our first session focusing on nausea, vomiting and constipation. Today, we are mainly going to see the next half, that is bowel obstruction. It is actually one among the mismanaged symptoms, I must say, because so it is one among the mismanaged symptoms, I must say, because it is quite often missed by many treating physicians as well. So today, we are going to discuss bowel obstruction and our main objectives for the day is how do we understand bowel obstruction, the classification, the symptoms of bowel obstruction, how do we diagnose bowel obstruction, and what is the management for different types, and also what is a treatment point of view, especially from a palliative care perspective. So before that, I think a case study will be helpful in understanding in depth what is bowel obstruction. Okay, here we have a 62-year-old lady. Her name is Mary, and she's diagnosed with stage 4 gastric adenocarcinoma with metastasis to peritoneum and anterior abdominal wall. She had a palliative distal gastrectomy followed by chemotherapy. Unfortunately, a repeat CT scan was taken after her 2 cycles of chemotherapy, which showed progression of the disease in the peritoneum and abdominal wall. So here I have a scenario. We'll come back to this case at the end of our session, and this scenario should be in your mind so that when we discuss, this lady's picture will be in front of us so that we can correlate. That is why I was putting a brief case report first of all. So now coming to the classification, there are 2 types, non-mechanical and mechanical. Again, intestinal obstruction means it is the restriction of normal passage of intestinal contents. So as I was saying, there is 2 types of bowel obstruction, non-mechanical and mechanical. Non-mechanical, when it comes, it is mainly paralytic ileus, functional obstruction, adynamic bowel. Can you say how adynamic bowel causes intestinal obstruction? What is the situation which causes it? Any condition that you're familiar with? Anyone, any idea?
Hypokalemia.
Excellent. Yes. Hypokalemia is a condition where a dynamic bowel occurs, and it can be a non-mechanical cause for intestinal obstruction. Here what happens is due to absence of normal peristaltic contraction, the bowel obstruction happens, and the pain here is comparatively less when you consider the mechanical obstruction. And as always, the bowel sounds will be absent here also. When we come to the mechanical obstruction, the dynamic obstruction is further classified depending upon the speed of onset, the site where the obstruction is happening, the nature of the obstruction, the etiology, what is causing the intestinal obstruction. Speed of onset, we can say it can be acute, chronic, or acute on chronic. And depending upon the site, it can be small bowel obstruction, large bowel obstruction. And depending upon the nature, it can be a simple loop, closed loop, or even a strangulated one. Etiology, it can be like intrinsic, extrinsic, and intraluminal factors, which is causing mechanical obstruction. So dynamic obstruction. If we go in detail, here what happens is bowel is capable of contracting normally or even excessively proximal to the obstruction. So what happens here? What can you see in your physical examination in this condition? When there is obstruction and there is excessive proximal to the obstruction, there is contraction happening. What can you see when you see the patient? On inspection, what can you see when there is obstruction?
These peristaltic movements.
Yes, excellent. There can be peristalsis. You can see the visible peristalsis happening there. On auscultation, what can you get? When you auscultate this person, what can you see? What can you hear? Sorry?
Absence of bowel sounds distally.
Yes, that can be seen. Sometimes there can be increased bowel sounds also. First, you can hear increased bowel sounds. Later, when there is complete obstruction, you cannot hear any bowel sounds at all. All right. So coming to dynamic obstruction, as I said earlier, it can be simple, closed loop, or strangulated. Simple, as the word says, it is obstruction at one point. Here, there is no vascular compromise happening. Okay. Simple, there is obstruction at one point. Closed loop means here the obstruction is at 2 points, forming a loop, grossly distended bowel, and there is risk for perforation here. Example, this is what we see in sigmoid volvulus. All right. In strangulated one, the blood supply is compromised and there is sharp, more consistent, localized pain here. There is peritonism and fever, increased WBC count can be seen. Signs of mesenteric ischemia is also present in this condition. So what causes this mechanical obstruction? There is dynamic and adynamic causes. Intraluminal, as I was saying, there can be impaction. Fecal matter impaction could occur. There can be foreign body which is causing the intraluminal obstruction. There can be bizarres. There can be gallstones which is causing the intraluminal intestinal obstructions. Intramural, the musculature, it can have the intestine can get strictures, or maybe even the malignancy, it is growing and causing obstruction of the lumen. Extramural factors like bands or adhesions following any surgery, or maybe even after radiotherapy, it can develop adhesions. It can be hernia, volvulus, or even intussusception, which is leading to this obstruction. All right. Adynamic causes, again, paralytic ileus, mesenteric vascular occlusion, or pseudo obstructions. Now, can someone say me what are the common symptoms that you see in intestinal obstruction? How will your patient present to you with intestinal obstruction?
Constipation.
Okay.
Vomiting.
Abdominal distension, pain abdomen, vomiting.
Okay.
Patient may go in for a shock.
Patient may go in for a shock when there is perforation, isn't it?
Not only perforation, if there is a valvulus producing ganglion, intersusception, all these things can cause a gangrenous and may go in for a shock, septic shock.
Okay, okay. What else?
Severe pain and vomiting is there. Distension of the abdomen are the main signs.
Okay. So, as you all said, these are the common presentation, how your patient is presenting with intestinal obstruction. Now, what is the cause for this obstruction? That is what here we are going to learn. Okay, as said earlier, there can be bowel distension. It is occurring because there is increased bowel contents and the increased gut surface epithelial surface area and increased bowel secretions. That is why this abdominal distension is occurring. This distension directly, what happens is it produces colicky pain. The bowel contraction occurs, and that is why it is leading to this much of pain. And the damage of epithelium due to bowel inflammatory response. This also causes the pain. When the abdominal, the bowel secretion increases, this in turn leads to nausea and vomiting. The intestinal contents are more, so the peristaltic activity is less. This leads to, again, bowel distension. Understood? So this is like a closed loop. The bowel contents increases, the motility decreases, the bowel secretion increases, the inflammatory response directly leads to the pain. Okay, so that is why the patient is presenting with all the symptoms. Now, what happens or how are we going to investigate further? Like, how do we understand at what level the patient has developed obstruction? How can we differentiate that? Now your patient is coming to you with these many symptoms and you understood there is obstruction. Now, how are you going to investigate further?
Depending upon the vomiting, whether it is bilious or non-bilious, so that we can find out the level of obstruction.
Okay.
Whether it, yes. Then simple test, we can do an ultrasound and find out, or an X-ray if there's a perforation, gas under the diaphragm.
Okay. Yeah, Surabhi is also saying palpation at different levels. Anjali is saying erect X-ray abdomen.
Generalized guarding will be there.
Okay.
Rebound tenderness.
Okay. So here, as everyone said, all of you are right on your own ways. But mostly when we go for home care, to get an X-ray done or maybe to have the ultrasound done is maybe very difficult. So and even shifting the patient from their house to a hospital facility is also difficult. So what we can do or what we have to keep in mind is trust the patient, take a detailed history. As sir was saying, you can also see what type of vomitus the patient is having. If it is bilious or not, is it feculent or not? Or is it only just the secretions that is happening? Is he having any constipation? Can we hear his bowel sounds? What type of pain he is complaining? What are the medications that he is taking? What was his last investigation? What all things have been understood from his previous CT scan, X-ray, or whatever is available from that? How do you think the patient is going to progress? All those things should be kept in mind. Okay. So the level of obstruction determines the pattern of symptoms. High level obstruction, that is vomiting, develops early and in large volume. Okay, if the obstruction is at a higher level, the patient will present to you with vomiting and in large volume. If the obstruction is at large bowel, it will be a progressive, abdominal distension will be more. If it is a complete obstruction, there is no passage of flatus or feces, or even patient can present to you with constipation or spurious diarrhea. What is spurious diarrhea? Last class, we have discussed that. Any volunteers? What is spurious diarrhea?
Diarrhea after constipation. Yeah, okay.
Can you say once more?
Impacted feces. I think overflow diarrhea is called.
Yes. Yes, urea is also saying about overflow diarrhea. It is actually the patient presents you with diarrhea. When we take history, there will be a period of constipation. After that, the patient is now presenting to you with diarrhea. Why diarrhea? Because the fecal matter, the newly formed fecal matter, it seeps down through the sides of the fecalith. And that is what the patient and the caregiver says to you as diarrhea, but it is actually not diarrhea. It is a fecal matter which is obstructing, and only some amount of fecal matter is coming through the sides. Okay, this is a sign of constipation. So patient can present to you with complete obstruction where he may have spurious diarrhea. Don't think that he is not passing, he's passing stool. So it can be a partial obstruction or subacute obstruction or something like that. Okay, so when you take history, you take a detailed history, keeping all those things in your mind. So again, if the patient is vomiting in large volume, it suggests that the patient may be having a higher level of obstruction or small bowel obstruction. If the patient is having severe abdominal distension and it is progressive, it can be a large bowel obstruction. If he is having complete obstruction, he may present you with spurious diarrhea or constipation, or maybe he may not be passing any flatus, and there will be absence of bowel sounds as well. Now, here, how do you diagnose? As many said, we can take a X-ray. In X-ray, you can see erect abdominal X-ray. You can see multiple air fluid levels. You can take contrast radiography with gastrogriffin, but we don't do barium. Here is another X-ray where the patient is in supine position and also in erect position. In erect position, you can see the air fluid levels clearly. Now coming to the planning and management of the disease. How do you think we should manage this patient?
Keep him NBM, start leaflets, and then investigate further. What is the reason for this obstruction?
Okay. Anything else that we can do? Nil per oral, rise tube aspiration.
Yeah, keep them nil oral.
Okay.
Start IV fluid.
Okay.
Correct the electrolytes first.
Okay.
Surgical obstruction has to be referred only.
Surgical, okay. So here again, when we see things in a palliative care point of view, on which patient we should go with surgery and which patient we should not go with surgery, these things should be kept in mind. Especially if the patient is having a poor prognosis, then surgery is definitely not going to help that patient.
Correct.
So this thing, how you make this point, how you identify the situation, how you convey it to the caregivers, all these things is very important in a palliative care point of view. So if the patient is able to tolerate this, only then suggest the patient, or we will think about a surgical planning, surgical management. So otherwise we'll have to go with conservative approach. All right. So as everybody said, you can do the, you can give IV fluids, definitely, especially when we go for home care. To get a IV is sometimes difficult. In such situations, we go with the subcutaneous infusions, which is much more easier. And even the caregivers can, we teach the caregivers also if they have to give. And also you can keep the patient NPO, but still the patient maybe saying there is increase in appetite, he feels like he's hungry. If such things happen, what we say is you can keep the patient in the upright position and feed him a little bit of water at some intervals if he's feeling thirsty or something like that. We ask them to feed him like that. We also put a Riles tube for decompression, because especially if the patient is continuously vomiting, there is fecal matter that is coming, then it is very quite distressing for the patient as well as the caregiver to be there. So we can put Riles tube as well if the patient is tolerating, and see how we can go ahead with that. So yeah, this is a chart where your patient is presenting with so and so symptoms of intestinal obstruction, and this is how you make a assessment and go ahead with what management you're going to do. Okay, so in clinical assessment, you see what are the symptoms he's presenting with. Investigations, as everybody said, you can take the X-ray. If ultrasound is possible, you can do that if he can be shifted to a hospital. But other factors are also playing a major role here. That is the patient factors, the disease factors, the technical factors. All those things should also be considered before planning and going ahead with your management, whether you need surgical management or conservative management. Coming to the patient factors, here you have age as the first criteria. But before age, I think the performance status of the patient should be given the first priority. As we say, age is just numbers, and that is true.
Oh no, what is that?
Yeah, so the performance status, if the patient is able to tolerate the chemotherapy, or if the patient is able to tolerate the surgery, then we go ahead with that. It doesn't matter at what age he is. Okay. Then you have the stage of the cancer. This thing should be constantly, as we all say, palliative care starts at the time of diagnosis. You have to be in constant touch with the oncology team in planning what is your plan for this patient, and correspondingly you have to do your palliative care along with it. Unfortunately, this thing is not happening, and that is where we find it difficult to convince the family. What happens is usually the patient comes to us in a very later stage where the patient has already developed all the symptoms, and at last we find it very, very difficult for the family to bear the pain and all that sufferings. So definitely the stage of cancer, what stage they are, we have to have a constant touch with the oncology team, what they are planning to do, what chemo they are going to do. Even chemotherapy or radiotherapy, it can be like palliative radiation or maybe a curative type one. So what are they planning for this patient? All those things should be kept in mind when you're planning for the management. Then future anti-cancer treatment options, what they are planning, and so and so. Then malnutrition. Is the patient able to have anything, or is he cachexia? Is he developing cachexia? Is he having concurrent illnesses like maybe diabetes or hypertension? Some other illnesses also will be having for this patient. So all these patient factors should be kept in mind when you're planning for a management. Especially in a surgical management, these things should be given first priority. Only then decide whether you have to take this patient for a surgery or not. All right. When it comes to disease factor, the extent of obstruction, that is it a single level of obstruction or a multi-level of obstruction? As I said you, there was simple, that is 1 point obstruction is there, 2 point obstruction, or a multi-level obstruction, or it can be even a disseminated stage of cancer where the patient is there. There, if you go for a surgical option, how much can you resect there? Isn't it? So all these things should be kept in mind. Whether the site of the obstruction, is it in a proximal level or a distal level? What is the etiology? What is causing this obstruction? Is it functional or a mechanical? Is it the tumor mass that is causing the obstruction? All these things should be kept in mind. Has the patient developed ascites? When there is ascites, if we do a surgery also, the possibility of regaining or coming back to normal is definitely very, what to say, it may not happen even. So all these things should be kept in mind. The carcinomatosis peritoneum, all these problems, if these things are there for the from a disease perspective or disease factors, if you consider, if all those things are there, then definitely you cannot go ahead with a surgical option. You have to be on the conservative side. And when we come to the technical factors, the degree of invasiveness, you can do an interventional radiology and see if it is, what to say, like how far the disease has spread. If that is possible, definitely you can do that. If the patient is able to tolerate to go through all these investigations, you can do that. If not, don't disturb the patient. The laparotomy, laparoscopy, any anesthetic requirements, endoscopy, all these are technical factors which you have to keep in mind. So these are the factors before you make any decision. Keep these factors in your mind. Only then you can plan your management accordingly. All right. Always keep in your mind regarding the performance status of the patient. If the patient is able to tolerate that chemo or radio or whatever it is, even a surgery, keep in mind if he's able to do it, only then go ahead with that. Now, these are the factors where it is a complete no for the patient. Complete no. That is, if poor surgical prognosis occurs, if the patient is having advanced age with cachexia. The patient is having advanced age with cachexia, then surgery is definitely a no. Widespread tumor or deranged metabolic parameters, then surgery is definitely a no. If the patient is having ascites, there is low serum albumin, there is severe nutritional deficiency, definitely that is a big no. If there is a palpable abdominal mass, previous radiotherapy to abdomen or pelvis, there could be adhesions. So we don't go ahead with any surgical options. If there is any history of any combination chemotherapy, multiple sites of obstruction, poor peristalsis due to diffuse carcinoma peritonei, poor performance status, if all this your patient is having, definitely don't harm the patient. Don't go ahead with any surgical options. Just give him some comfort care, and that we will be discussing in detail. Okay. The patient will be presenting you with severe pain. Definitely we can treat the pain. Sometimes he may be presenting to you with so much of vomiting in large volume he's presenting. We have something to help him. Okay. So always keep in mind the patient factors, how he or she is presenting to you, what can be done for their favor. All those things should be kept in mind. Now coming to the treatment options, we have pharmacological, we have laxatives. What type of laxatives do you prefer here? Since we have completed the class on laxatives, anyone? Is it bulk forming, stool softener, stimulant laxatives?
We have to use stool softeners.
softener.
Avoid using bulk laxatives.
Can you please tell me why do we avoid that?
It will cause more obstruction if it gets it will not help for the peristalsis of the intestine if you use bulk laxatives.
Yes.
It may add to pain and obstruction.
Yes, excellent. So here what we usually prefer is stool softeners can be tried. We can try enema. We can do a PR and see what is the condition. And if it is balloony rectum, definitely there is constipation. You can insert your suction tip and push in your enema. And after that, we can see. Before that, you have to check for the bowel sounds and all that. Physical examination part should be done. And usually we prefer to give enema or maybe stool softeners, etc. Okay. And also next we have corticosteroids. What corticosteroid do we give here? And why do we give corticosteroids?
To reduce the tumor edema.
To reduce edema. Okay.
Adhesions also.
Okay. Which steroid do we use?
Dexamethasone.
Why do we use dexamethasone?
To reduce the edema.
Yeah, that's true, ma'am. Why do we choose Dexa? We have Hydrocort. Yes, Malati Ganesh, she is saying we can use Hydrocort. Why we are not using Hydrocort, or why are we preferring Dexa? Okay, we prefer dexamethasone here because it is long acting. It is long acting, so we prefer dexamethasone. And also it causes, it helps in reducing the peritumoral edema. Okay, the intestinal, the intraluminal factors which we are discussing, isn't it? The tumor is expanding and there can be edema around it. All these things can cause severe pain, as well as it can lead to vomiting and intestinal obstruction, so and so. It's like a vicious cycle. So it helps in reducing the peritumoral edema. It is long acting, and it should be given as a single dose in the before noon time, especially in the morning dose we give. Why we give in the morning time? Because if we give it in the later part of afternoon, what happens is the patient will have difficulty in sleeping. So we prefer corticosteroid, especially dexamethasone. It helps in reducing the peritumoral edema. Okay. So that is why we use dexamethasone. And we have antiemetics. What is a common antiemetic which can be used here? Sorry.
We avoid domperidone can be used.
Okay.
And ondansetron otherwise.
Okay. Can we use metoclopramide here?
No, we avoid metoclopramide.
No.
Ma'am, actually, we can use metoclopramide if there is, if we can hear bowel sounds, if there is some amount of motion he is able to pass, that means there is a partial obstruction. If it is a partial obstruction, we can give a trial of metoclopramide and see if the patient is developing any severe pain. If he's developing severe pain or something like that, then yeah, if he's developing
the mobility, no? Actually, for complete obstruction, definitely we don't use. Even for partial obstruction, because it affects the mobility of the intestine, no? So
Yeah.
we avoid using.
Yeah. So depending upon the situation, you have to be careful. If the patient is developing severe pain, worsening of any symptoms, then you stop metoclopramide, and then you can give, as ma'am said, you can give ondansetron, and even the best antispasmodics like buscopan, your butyl bromide can be used here. Okay, it helps in decreasing the secretions as well. Okay, then you can use anticholinergics. Somatostatin analogs like octreotides can be used. Then analgesics. Analgesics, here again, morphine can be tried, even though morphine can cause constipation, but it is not a contraindication here because the patient will be in severe pain. Okay, now surgical, there can be resection of the bowel segments, colectomy, ileostomy, or colostomy. Yeah, in ileostomy, it is more difficult. Even colostomy is very difficult for the patient. In ileostomy, the drainage or the passing the fecal matter or this thing will be very high. It is more difficult for the patient than colostomy. Ileostomy is more difficult. Okay. Now, invasive procedures, as we said earlier, we can use nasogastric tube. Gastrectomy can be done, or colonic stents can be done. So as I was saying, in antiemetics, we can use metoclopramide domperidone antagonist. Here we start at a dose of 10 milligrams 8 hourly. We can try sub-Q. Gradually increase the dose day by day. Definitely check for any symptoms which is going the other way. If so, we stop it. Okay. Even metoclopramide can be given as subcutaneous infusion also. Then we have 5-HT3 antagonists and prokinetics. Only in partial obstruction we use it. Okay. Haloperidol is very good as an antiemetic, which is used for nausea and vomiting. The starting dose can be 2.5 to till 20 mg. We can go higher if required over 24 hours. And this can be set in subcutaneous infusion. Next, as we said, we have corticosteroids. Usually we can start at a smaller dose, and 16 mg is maximum. But I have seen doctors, my seniors, even prescribing higher level depending upon the case. Okay, even 24, 28 I have seen. So depending upon the case, it can be increased, but usually we can start from 16 and see how the patient is responding to it. It is actually a long-acting corticosteroid. It should be given before 3 p.m. As I said earlier, late administration can interfere with the sleep of the patient. Usually it is given as given for 5 days and we taper it slowly. Okay. If vomiting subsides, we change from IV or subQ to the oral steroids. Steroids act by reducing the peritumoral edema. This is very, very important. We have to say it like this itself, like it acts by reducing the peritumoral edema. And we have to monitor the patient's blood sugar levels because steroids can increase it. So we have to daily monitor the blood sugar levels. Next, we have somatostatin analogs. Most commonly, what we use is octreotides. The dose is from 100 to 600 micrograms per day. What octreotide do is it will reduce the secretion, slow down the motility, reduces the splanchnic flow, and increases the absorption of water and electrolytes. And it is a potent vasoactive, potent anti-vasoactive intestinal peptide effect. Okay. It also tried as a preventive step. It is also tried as a preventive step. And we have depot preparations available for this. But only thing is, it is very expensive. And most commonly, we don't use it. We prefer using buscopan, hyoscine butyl bromide here. And also it is used with steroids in carcinomatosis peritoneum. Now, the medical management, this is how your prescription should look like. First thing, what you have in your list is dexamethasone. You can start from 8 or go up to 16 or even more as required, depending upon the case. You have to give it for a trial period of 3 to 5 days. Okay. Next thing on your list is metoclopramide. It can be given as 30 to 120 milligrams over 24 hours for its subcutaneous infusion, or hyoscine butyl bromide. I've put a or. We don't give both together because metoclopramide is prokinetic and hyoscine butyl bromide is not. It causes the stasis. And it also has a chance of causing constipation, but still it helps in reducing the secretion. So depending upon the case, you have to give metoclopramide or hyoscine butyl bromide. We don't give it together. Always keep this in mind. And for the vomiting, you can also give haloperidol 3 to 20 milligrams over 24 hours as subcutaneous infusion. We also give ranitidine anticholinergic. It blocks the H2 receptors, and you can give it around 300 milligrams per day. So this is the prescription, how it should look like. Now here again, we have some common questions which strikes us. How are we going to see the hydration? How often should we feed him? Or is there any role for total parenteral nutrition, nasogastric tube, gastrostomy? What do you think? How should we hydrate this patient? Anyone? Your caregiver will be coming and saying, oh, doctor, he's in severe pain. He's not even having anything. Please put some IV fluids. Will you do it? Or per day, how much IV
Hydration,
fluids?
maintaining.
Yes, ma'am, please.
No, maintaining hydration is very important. Depending on its body weight and the urine output, we can decide on how much intake to give and then monitor. Like depends on the other parameters as well. What about his electrolytes? How are they? Depending on that, we have to decide about which IV fluid to give.
Yes. So the patient here, he is on rice tube also. So the patient will be saying, I am on rice tube, even though they are feeding me, I feel very thirsty. I am feeling hungry. I need to eat something. These are the common requests which comes, especially when we go for rounds. The patient will be saying, please do something. I'm really feeling hungry, because we have seen patients requesting us, please do something. So what happens is, even though the patient is on rice tube, even though we are feeding him some very soft diet and all, they will feel hungry. What happens is the oral cavity will be very dry. So that dryness causes this increased thirst sensation. So what we do is, we should, even though the patient is on rice tube, we should give a good oral care. Oral care is very important. You have to check his oral cavity, see if there is any candidiasis. In the last class, we have discussed all this, the importance of oral care. Check if he is developing any candidiasis and give the oral care. And in between, you can ask the patient to take sips of fluid and try in a sitting position, or elevate the bed and ask the caregiver to give sips of fluid. Even if he's not able to drink, with the cotton dipped in water, just wipe his lips. Is he trying to drink? Check all those things. Okay, that if we are able to do all this and he's feeling okay, then it's good. The patient will say, okay, now I'm feeling much better. That dryness, no, you have to always keep in mind. And also the oral feeds. Definitely, usually a person who is in rice tube, we say every 2 hourly or 2.5 hours, you can give up to 200 to 250 ml, you can give. You try giving it. If it is okay, you can continue. If not, we may have to reduce it, depending upon if he's vomiting or not, if it's not being managed with all those things. Again, you can give IV fluids. One IV fluid you can give per day, that too very slowly. If we overhydrate also, it can lead to increase in secretion and in turn lead to vomiting and all that. So you have to be very careful. Nasogastric too, so this is the main thing which you have to keep in mind. Now when you come to total parenteral nutrition, so the total parenteral nutrition is justified in patients with minimal tumor burden or candidates for definitive surgery and in patients with good performance scale. Only then you can try total parenteral nutrition, especially if it is used in good life expectancy. Okay. And also people, for them to afford this thing is also a bit difficult. Sometimes adverse effects can also occur. Okay. So, yeah, here again, we are coming back to the first case, which we started on with. Mary, she's a 62-year-old woman. She's supported by her children living in UK. She was diagnosed with stage 4 pediatric adenocarcinoma with metastasis to peritoneum and anterior abdominal wall. She had a palliative distal gastrectomy followed by chemotherapy. Unfortunately, a repeat CT scan showed that there is disease progression and it is spreading to peritoneum and abdominal wall. She also had vomiting and abdominal colic for 2 days, but was still able to pass small amount of stool daily. She had vomiting 2 to 3 episodes per day, which was unrelated to meals. The vomitus was bilious with partially digested food. Now, where do you think is her obstruction? She's having bilious vomiting.
Duodenum. It is called.
Small
Yes.
intestine.
Duodenum. Yes.
Small intestine.
Yes, yes.
Duodenum.
So it is in a higher level obstruction or in the small intestine she's having. And on examination, she was not dehydrated. Her abdomen was distended. Bowel sounds was sluggish. A palpable nodule was present on the abdominal wall, which were mildly tender also. So here, what we understand from this is she's having a partial obstruction in a
Partial
higher
obstruction.
level. Yes. Yes, sir. Do you want to go ahead?
Partial obstruction below
Yeah.
the second part of the duodenum.
Okay. She's having bowel sounds. It is
Yeah,
sluggish.
but it's
And
passing stools also.
yes.
So it is an indication there's a partial obstruction.
Yes. Yes. So these are the pointers or these are the indicators saying you where the obstruction is. Even if you don't have an X-ray, you don't have a portable ultrasound when you're going to see her, still it's okay. From her history, you should be able to make out what is she having. Okay, these are the indicators. So once you get an idea, even though you are at home care, any rural part of the place, it doesn't matter. If you are able to give comfort care, that is what we are trying to do here. Okay. Now, in view of persistent vomiting, a nasogastric tube was inserted for her, and she was told that this tube would be temporary measure for decompression. A CT scan was taken and it showed a small bowel obstruction with a transient point at proximal jejunum. She was still opening her bowels. The impression was partial rather than complete obstruction. Intention of management was to reverse the obstruction. Now, this was the treatment that was given. She was given bisacodyl suppository. At regular interval, IV metoclopramide was given 10 mg every 8 hours, and intravenous dexamethasone 8 mg per day was given. Now, do you think this is sufficient? This was the treatment which she was given from the hospital or the treating physician. What do you think about the prescription?
Bowel evacuation is done. Antiemetic is given.
Okay.
Dexamethasone given to it's long acting. Edema subside. Yes.
Doctor, is this dose enough for her?
Gain also. Bisacodyl or something.
Dexa dose probably can be increased.
Dexa, yes. Dexa can be given tedious, 8 hourly.
Okay. Dexamethasone, sir, also I have said you, we don't prefer a tedious dose. We
Yes,
usually give it as a single dose in the first
Single
half of the day because it causes some sleep disturbances.
Sleep disturbance.
So anybody wants to correct this prescription?
Depending upon the symptoms, this has been followed, but we'll have to see whether the vomiting is still persisting. Then we can increase the metoclopramide dose. And evacuation of colonic evacuation, if it is fully evacuated, not necessary to give any more suppository.
Fentanyl infusion.
Started.
Yes, that is a next half what happened for her. Actually, suppository, bisacodyl suppository is not enough for her. You have to do a PR and see what is the condition of her, what to say, is there any motion in the rectum or is it a balloony rectum or is there a chance for manual evacuation? All these things should be kept in mind. So simply keeping a suppository is not going to help her. After doing a PR, you have to give a enema if required. And the next thing is at regular intervals, they were giving her metoclopramide. And what happened after some time? She started developing pain. And for that, they started her on fentanyl infusion. What does that suggest? she's having worsening of symptom. That means we have to stop metoclopramide there. Okay, and also the dexamethasone dose is not sufficient. You have to start at a higher level and then taper it down. Okay, you have to give at least 16 milligrams per day as a single shot in the morning and then see if it is helping her. If you start at 8 milligrams, it is not going to help her. So this prescription should be rewritten. And what happened is she developed pain. And again, what we did was we did fentanyl infusion for her since there was worsening of nociceptive lower abdominal pain from the peritoneal metastasis that had been present for two months. Now, there is no bowel action after that. There is, that is the IV metoclopramide was increased to 60 milligrams per day on the following day and marked clinical improvement for 2 days later. That metoclopramide dose we tried to increase because there was some amount of the bowel sounds we could hear, and afterwards, after some time with the fentanyl infusion and all that, her pain also somewhat subsided. Now what happened? After some time, the treating doctor was able to remove her nasogastric tube and started her on oral fluids gradually. Intravenous metoclopramide and dexamethasone were continued for 2 days and stopped abruptly. 3 days later, she started to vomit again. She had 3 episodes of vomiting in a day, which contains moderate to large amount of bilious vomiters. She was recommended on intravenous metoclopramide 60 milligrams per day and dexamethasone 8 milligrams per day. In addition, IV ranitidine was added to reduce the gut secretion. Despite the above treatment, Mary's symptoms persisted. Now, what do you think happened here? The team of doctors, after some days when her symptoms got somewhat okay, they removed the nasogastric tube and they also stopped the intravenous metoclopramide and dexamethasone. So what they did, what went wrong here is they stopped these medications abruptly. You should not stop these medications abruptly. You should taper it down. This is another catch here. Okay, so even if the patient is showing some signs of improvement, you have to be very patient and see. Let's see for 2 more days and then only taper it down. And once you taper it down, later you can change it to oral and see if she's tolerating it or not. Okay. So the goal of care was established after discussing with the patient and her family. She preferred to keep the nasogastric tube for decompression while she enjoyed taking her oral fluids. This was done next. The decision was also made to stop further chemotherapy and for comfort care. She returned to home with home hospice support. Actually, now what happened here is she went through so much of pain. She had so much of vomiting. After that, at last, she had some amount of pain relief with all this, your dexamethasone, your antiemetics, everything. And now she's somewhat comfortable. But actually, what could we have done before, prior to all those sufferings? How could we prevent? How would we have been prevented all those things? Like the goal, as I said in the initial session itself, during the diagnosis itself, you have to consult with your palliative care team and then try to understand. See, this lady I was saying, she was from UK. Her children are from UK and they had financially, they were sound. Even though you are financially sound, you have no, all those problems or anything like that. Still, what you have to keep in mind is what is the patient requiring, what does she want? If she doesn't want any surgery, if she doesn't want any other kind of this thing, leave it. She should be comfortable. So that is the one thing you have to keep in priority. Even if you have all those facilities available, it is your choice. If you are comfortable, it is your choice whether to choose. It is patient autonomy. It is her choice to go ahead with it or not. She should not suffer. So ultimately, that is what we all need. So at the point of time of diagnosis itself, you have to make the patient as well as the caregiver understand what she is having, what are the future complications that could occur in future, and how can we manage all those things. These things should be kept in mind, and we have to proceed further. So now we know what is the classification for intestinal obstruction, what are the symptoms, what is the diagnosis, what is the management, and things we have done from a palliative care perspective. Yeah, so we come to the end of the session.
Ma'am, I have a question. If somebody is allergic to metoclopramide, what are the other drugs you can give?
Yeah, you can try Enicet, ondansetron. You can also give hyoscine butyl bromide. You have your haloperidol. You have dexamethasone. See, there is no one particular drug that you have to treat a particular, especially in nausea and vomiting. It is actually one or more than one drug should be given together in order to control, especially refractory vomiting. Instead of metoclopramide, as I said, you can use all these things.
And one more thing, you were talking about subcutaneous infusion. What is that?
Subcutaneous
Any drug
infusion.
could be given. That is another route of administration.
Yes.
See, because what she was trying to say, thank you very much, Dr. Sangeetha. I'll just give a quick
Yes, ma'am.
overview. And then, see, basically, it's another mode of administration. What we all, when you are looking at palliative care, you have to understand this. Many times, what is routinely done may not be possible, but that doesn't mean we are giving up on anything. We have to look what is the other alternative. See, even in hospitals, you have we see defined, described. We have a very many groups of antiemetics available. So we will decide on what is appropriate for that particular patient. So, as for example, laxative, we have bulk stimulant. So we will not give a bulk when the indication is not there, and we will give a softener when we want. That is the aim. So similarly, we have the type of antiemetic or laxatives different according to classification. Then we have according to route of administration also. So the subcutaneous route is something, especially in home care and in palliative care. See, you may have a cachectic patient. IV access may not be possible even for an expert. So that doesn't mean we are not making the patient struggle. So subcutaneous can be done by the home care team, and even the carer need not be worried. If it is an IV access, if it is not going properly, they may not be able to pick up, and there may be a big bulge, and that will cause more pain and discomfort to the patient. Whereas subcutaneous can be done with a small butterfly, you can do. So these are other modes, but by using a subcutaneous, you're still delivering the medication. Two things, still we are able to give the medication, and it could be given in a rural setup. See, home care is something all of you have, especially palliative care from the beginning, as I say, two broad things: hospital-based palliative care, home-based palliative care. Another thing, total summary again and again, patient's best interest. Dr. Sangeetha put things across very well. Exactly, that's what I'll say. Everything may be available. Because it's available, it need not be used. I don't want to be too blunt. As she said, no, the carer or family had all the money, but the patient is whom is the best interest. What does the patient want, and what are you doing to the patient? The patient, he or she is satisfying them is our goal, and at the same time we are doing good and no harm. the main important things of palliative care, all of you: autonomy, doing good, no harm, and then resources used appropriately. And by doing some procedures and things, it causes more discomfort to the patient. Our main aim is to alleviate suffering. Another thing is, many people are unaware. Many don't know what is palliative care. Many
Ma'am,
think
how
palliative
much you
care is
can
end
give
of life care.
subcutaneously? How much you can give
It dep-
subcutaneously? Then how is it calculated?
Let Dr. Sangeetha herself explain, maybe.
Yes.
Usually, it is actually we give it as actually I don't remember the exact what to say. We have a guideline for that. I think we can share it after the session with you. It is actually taken for, it is administered by the nurses. We have a class for them. We just give it in a what to say, this is our dose.
That's
and
what,
we-
ma'am. My doubt is a small extravasation will also cause some amount of pain and
Yes,
filling and infection.
see,
Yes,
When you
for
give subcutaneously, how is it possible? You can small doses like insulin you can give, but for fluids and nutrition, other medications, how is it possible? I just
they are
wanted to
given
know
like
for my,
intermittent doses, doctor.
yeah.
They are given on intermittent doses. You have like if it is a subcutaneous infusion for 24 hours, and they have syringe drivers. So it all depends on how you're going to give. Again, route of administration. Is it an intermittent subcutaneous dose, or it is a continuous subcutaneous infusion? If it is a continuous subcutaneous infusion, you have a syringe drivers are used. If that's all, again, those are expensive. So you use 4th hourly, 6th hourly, this much amount, where you are placing the subcutaneous cannula. So there are very many things. There are specific guidelines for how it is to be given, and that is what she will share. Is that right, Dr. Sangeetha?
yes, definitely, ma'am. Usually that is a class,
That's
entire session on subcutaneous
exactly,
infusion
yeah.
is there, but
Because
that is
there is
usually taken for nurses.
nurses.
Yeah, but I can share the slides. Maybe
Thank you. Yes, better to share, because that's what it will be, doctor. You have subcutaneous 24-hour infusion
Yes.
drivers.
Yes, as
Okay,
ma'am said,
hospice
we
care
use
has all this.
yes. We usually use the syringe drivers.
So you have specific things. If it is for 24 hours, see, painkillers are given, haloperidol is given, and like I have used it also, doctor. I have used it both as an intermittent and as a continuous one. Continuous one will be done by the palliative care team with the syringe driver. Intermittent ones can be given, like few mils can be given, and that will not cause a large amount of bulge or anything, doctor. So that shouldn't be an issue. Small like when you're giving medications, it should be okay. For infusions, again, they have specific protocols and guidelines for it. Is
Thank
that
you.
clear for you?
Yes.
Okay, no problem. We'll share that also. And as I said, no, all of you, main thing, explaining everything to the patient and the carer. One good thing I'll tell, especially anything what you're trying to say, many patients are not aware. Okay, once you explain to them both the pros and cons of it, and give them some time for them to think and make a decision. 8 out of 10 times, they make a sensible decision for themselves. Only thing, you have to have the patience to tell them. Even NG tube, okay, they might not have known. Many people will think, oh, will you put the NG tube every time you're going to give me the feed? You'll put it in every time and take it out. That's what they think. Then when you explain it, oh, it's all, then they take time and make the call. Oh, am I going to have it or no? So everything, they are all unaware of it. So raising awareness is our first goal. And then next, explaining to them what it is. Then mostly they will make the decision. Then help them comfortable, maintain their dignity. If it was you, what would you prefer? They don't know things, so explain things to them. You have to obtain all the knowledge. So this main aim and objective of this course is for all of you to obtain the knowledge, then take effort to impart the knowledge and improve the service of palliative care. That is what it'll be, a two-way thing. You will also be benefited, and you'll be able to benefit the general public, both the patient and the carers. Now go ahead, either if you have got, let me check the chat box. Patient is diabetic. Then we can use corticosteroids. If yes, then what is the choice or alternative? Sangeetha, go ahead. If not, then I will add on.
Okay. Usually, even if the patient is diabetic, we give dexamethasone. What we do is we can give insulin. You can use human atrapid to control her blood sugar levels. But we prefer using dexamethasone itself because that is the only thing which is going to help her.
That's what I would also say. We have used, doctor, it's not managing the insulin is no big deal. It can be managed. The amount of benefit that you get from DEXA is way beyond anything. Especially even for as an antiemetic, it does. We as I have been an anesthetist, we try everything. But like especially post-operative nausea, vomiting is a very common thing, and it is gender-based, surgery-based. So many things are there. Even in those type of situations when nothing else works, DEXA works. Okay, so DEXA has its own benefit when it is used sensibly and wisely. So at that point of time, you can manage and control the diabetic condition better off, because if they're going to be sick and vomiting all the time, electrolyte imbalance, so many other things you have to correct. Whereas by correcting this and giving some amount of rest to the patient, it is more helpful, and managing the diabetes or the sugar levels can be done in very many ways.
Yes, ma'am, Dr. Tribeni here. So what I understood about this question, that because the primary issue or the problem is here the vomiting, so we have to solve that. We have to comfort the patient with a stat dose or something like that. But we cannot long term, if needed, what we have to do, because that will be if patient is vomiting for
no,
2 or
like
3.
see, for using it for 3 to 5 days is not a big deal. You can use it, and at the same time control your insulin, control
level.
the diabetic sugar
Status
level with the
also.
insulin.
Okay.
Yes, simultaneously
There
you
is
see
no
when you have a very
contradiction.
sick patient. No, it's not a no contraindication at all. In this situation, risk benefit ratio is what all of you have to take home. Many such situations will come. That is where our knowledge and expertise comes. In you do the risk benefit ratio, is the risk superior, or is the risk higher, or the benefit higher? So if I control that, controlling the sugar level with insulin, I can manage. So that is how you have to see, and you can check the blood sugar levels 4 hours, 4 hourly, 8 hourly. Do that and check. It will be a little bit more of a demanding job both for the doctor and the nurse.
True. And this patient will, if severe vomiting and patient will go into shock, then it will be difficult to recover. Yes, okay.
Exactly. See, that's where we're all coming to.
Okay, thank you, ma'am.
No problem. Multiple electrolyte imbalance, especially we don't want with diabetes.
No. Okay, thank you, ma'am.
Go ahead. Either unmute and ask, or where you want to. Is there anything more in the chat? Okay.
Ms. Mallika is asking about the pain. Yes, definitely pain should be controlled. We can use morphine or fentanyl or whatever it is going to help her. We use that and see. And here also, we don't give it orally. It will be a continuous subcutaneous infusion using a syringe driver. She'll be on multiple drugs, like morphine she'll be having, steroids she'll be having antiemetics. So all those things will be going together. The patient will be very sick, so she will not be able to tolerate anything orally.
Patches will also play a role in these type of situations. Patches, PR, everything, or you're supplementing, like additive effect, whatever you can obtain is what you will all think. In those type of situations, even a PR paracetamol might help. So you have to use all modes and routes of administration, and keeping her comfortable in all forms is the aim and goal.
Ma'am, I think we can move on to the case presentation now.
Yeah, good evening, everyone. I'm Dr. Sugin Glenn Basil. I'm a medical officer in Life Care Hospital, Nagarkoil. Yeah, my case, he's a 71 years male who was diagnosed as a metastatic renal cell carcinoma. He presented with complaints of abdominal pain, abdominal distension, constipation, low backache, and vomiting. For the past three months, it was a history. 3 months back, he was apparently normal. Then he had the low backache, which started first, which was associated with difficulty in vomiting. Initially, the orthopedic surgeon opinion was obtained for that. Then MRI, LS spine, and abdomen was taken, which showed a renal mass with D11 vertebral beds. Then he was started on targeted chemotherapy after taking histopathological examination. Now after that, he presented with complaints of abdominal distension, vomiting, and constipation. On examination, there's no signs of any infection, and then his abdomen was distended, stretched, and shiny. Initially, NG tube feeding was done. Then ascetic fluid tapping was done for the symptomatic relief for the distended abdomen and pain. Then analgesics were given. Then he was planned for a radiotherapy to spine if the pain is still persistent. X-ray abdomen erect showed multiple air fluid levels. Then a USG abdomen was taken, which showed suggestive of small bowel obstruction. Then the blood investigations showed the low hemoglobin, elevated total counts, elevated CRP, low sodium, and urea, creatinine, and the LFT were within the normal limits. And the psychosocial aspect for this patient is he was living with his wife and a differently able daughter. He was very much worried about her daughter more than his ailment at that time, because he used to say like that, and who will take care of my daughter? I mean, if something happens to me like that, and he was very afraid of his death, and he had a loss of hope. Coming to the medications, the targeted therapy, he was started on tablet sunitinib 25 milligram OD. For the pain, he was started on tablet morphine 5 milligram 4th hourly. And then the injection ondansetron IV was given. Injection pantoprazole IV was given. Then antibiotics for the LRI part, because he had some lower respiratory tract infection also. Then nebulization were also given. So main concern in this patient is the pain management initially. Initially he came with the severe low backache and abdominal pain is a little bit lesser, but the low back pain was very much concern for the patient. Then the symptomatic relief, the abdominal distension, pain, and vomiting also. Summary, this 71 years male was diagnosed as metastatic renal cell carcinoma with vertebral metastasis. He was started on targeted chemotherapy. He developed signs of small bowel obstruction, which was treated conservatively. Then he was treated with analgesics, antiemetics, laxatives, etc. Ascetic fluid tapping was done in frequent intervals for the symptomatic relief. He was much relieved from the pain part, but all of a sudden he had an aspiration pneumonitis which became severe, and he just passed away 3 months after the diagnosis of his ailment. The discussion point, I just want to know about the dietary advice in such patients, because he can't eat very much of food, and he used to complain of vomiting if he eat anything. Yeah, even if you give the antiemetics also. Then I just want to know about the dietary advice. Then the palliative surgeries indications, but it was explained by a ma'am now. Then the family support and the emotional strengthening. Family support, how to support these family members with how to care these kind of patients. Then the emotional listening from him, the psychosocial support we have to give for. Thank you.
Thank you, Dr. Sugin. Exactly. You as Dr. Sangeetha took us through today, you have brought what is essential in this. We will ask our make it open for our team to come up with either queries or discussions, what they want to in the chat, or unmute and speak, and then we'll take it from there. Okay, as the first thing, dietary advice is last session, Dr. Sangeetha did mention small, frequent. See, again, this is what we have to teach to them. Okay, and as all of us know, we are all used to 2 big meals, maybe 2 big meals as routine, or 3 maybe. But we have to, because of the condition, again, explaining to them what the issue is with him, so many other issues, and he's already having the general condition deteriorates. So we have to explain to them the need for small frequent meals, and also what and how has to be given. And as you said, palliative surgeries, madam has took us through. Family support is psychosocial support. Again, carers have not only the patient, we have to explain to the patient and the family also what the condition is. If the family forces him to eat 2 big meals, is it possible for him? No, not at all. So for that condition, we need not put the patient into such a stressful condition if you explain it to the family first. You tell them how they have to feed him, what has to be given. I would even say small quantity nutritive meal. So if you just give some liquid, he will be hungry, but still he can't eat. So, and then next thing, if he is very sick, giving the advice on antiemetics, and then wait for some time. If it is just 1 or 2 vomiting, give the antiemetic in empty stomach, give 45 minutes. All these may sound very silly and simple. But if you explain things to them, give 45 minutes for the medicine. If you're giving something orally, give time for it to work. So it's as many doctors don't have time to even explain anything, but that will do no good to us or to the patient. So you have to explain. If you want to have success in your practice, you have to tell what has to be conveyed. So explaining to the carers the need and the benefit of the medication, and explaining to the carers how the feeding has to be. So those things, and emotional strengthening and things, you have to do a few sessions of counseling with him individually and with the family separately, and then combined counseling for patient and carers. Those type of things have to be done. Sangeetha, if you want to add on anything, please go ahead and do. Somebody has mentioned in the chat, nutritious, tasty food. Exactly. Do something what they like and give in small quantities. Like normally vegetable soup, or no, like whatever non-veg soup or something like that, which is nutritive, small quantities. Exactly do what they like. Even that small quantity, they will eat if it is something that they like. Sangeetha, go ahead, Sangeetha.
Sorry, my mic was muted. Sorry about that. Yeah, especially in this situation, the family, the caregivers will be like, oh, he is diabetic, he can't eat all those things. You have to be very strict. You don't have to be very strict on his diet. Let him eat what he likes, whether it be sweet, sour, or whatever it is. If he is feeling like eating, let him have a bite of that. You don't have to be very strict with what he is eating and all that. So yeah, and also small frequent feeds. Most importantly, have a good oral care. That is also very important. And in between, you can give sips of fluid for him to have and see how he's responding to that. And coming to palliative surgeries, it was discussed in detail. All those things should be kept in mind, the patient's performance status and how you think it is going to help him. Especially have a good communication with the oncologist, the treating oncologist, and see how it is going to, how they are planning to proceed further, and how that decision making is going to impact the patient and the family. All these things should be kept in mind. Now, coming to the family support. In our hospital, we have a team of psychologists and social officers who looks into this matter, where it is being understood in great depth, and we try to help them. If especially if there is a child in the family, their education is a big concern for the patient as well as the wife or the other family members. So what we try to do is we try to get some education support for these families, or we try to link them to some other people who is able to support this family. All those things, even if you don't have a social worker in your hospital, at least you can try. If somebody can help this family, you can find some other sources. Especially in every hospital, you might yourself have a team of doctors or nurses, somebody who is able to support them financially or some other way, at least buy some ration for their house for the next month or something like that. Some kind of small gestures is definitely going to help them in a big way. So these are the emotional factors or things which is going to directly, what to say, like impact the patient. All this thought itself, like how my family is going to live if I'm not there, can cause severe pain for the patient. I hope the pain class is over. So all these factors definitely will have an impact on the patient. This can be a cause for the pain which the patient is suffering. It may not be the physical pain the patient is going through. This may be the emotional stress, the emotional factors for the pain, the spiritual factors for the pain, adding on to all the sufferings. So all these things you have to keep in mind. The patient should be seen as a whole. You should have that empathy for that patient. You should have sympathy, empathy, everything should be there. See the patient as a whole and try to understand what they are trying to convey. Sometimes they may not even open up to you. It is very difficult. Still, once they feel that you are understanding, you are being a good listener, they'll slowly start opening up to you. Be a good listener in your practice. This is definitely going to be a game changer there.
Exactly, dear. And I was also about to say about pain, what was his concern mainly to add adjuvants. Pain, what you have had 3 sessions of the basic pain ladder, and adding on the adjuvants, treating total pain is all very, very important. So being willing to look into all total pain, the 4 aspects of total pain has to be done. And per se for pain management, I would say follow the ladder, add on the adjuvants. It's very, very important, especially when they've had, for this patient, I would say with the issue with the spine and things, adjuvants do a very good role. And when you add on the adjuvant, they get some amount of sleep. That sleep being naturally, they would have been deprived of sleep for very many days. So that itself gives them the confidence that they could also sleep, something like that, rejuvenation. So many factors are there. So keeping in perspective and being communication is another important. We have covered all these things in great detail. Please remember and recall all those things every time you see a patient, so that you will be able to fulfill and do justice to everything.
Okay, now in this prescription, do you see any mistake in this, everyone? Anybody likes to add something?
They should pick up now after your talk immediately, Sangeetha.
Yes.
Come on, is it coming up on the chat, or is someone come? Someone
yes,
has typed on the chat. Let me see. Another import. There
Yes.
it comes. Very good. That's what I was waiting for. Is that right, Sangeetha? You would have
Yes,
also been
definitely. That is why I went back to the slide.
Very good. Good. See, happy all of you are active, and see, only when you're all happy and coming up with things, it's a two-way thing. We are trying to impart something, and we'll be happy when all of you have picked up. A big multiple hats off to all of you, being attentive and responsive.
Crown to you, ma'am.
Oh, thank you. I'll be very happy if all of you are able to practice well, and end of the day, be happy in yourselves too.
Okay.
Is
Thank
there
you so
anything
much.
else? If not, I think, is there something else on the chat? Add haloperidol, okay, instead of on, etc. Yes, see, all antiemetics can be tried, and it is individual patient, and we are all not the same. We are all made different, and we will respond also differently. So take it as individual patient wise, I would say. Anything else, Dr. Sangeetha, you are about to say?
Yeah, when we write morphine, definitely there should be laxative
Correct.
with it.
Yes,
There is no
without,
compromise in that.
no, I would say without laxative, it's negligence. Okay, when you know that it can cause constipation, if you don't give, I wouldn't be very calm and kind in that, Sangeetha. It
Yes,
is not
ma'am.
good practice to do. See, we have to teach the right thing. If there is no prescription of a laxative, you're not doing justice.
Yes, and also when
Incorrect
we come to
prescription, I would say.
laxatives, you can use stimulant laxative, your bisacodyl as 10 mg HS dose, and also along with that, always use a stool softener. Okay, and suppository. We have Amar Pawar saying about the suppository. Suppositories usually how we give us, even after giving stool softeners and stimulant laxatives, even on the third day, if he's not passing any stool, we ask the caregiver to keep a suppository and make sure the suppository is touching the rectal mucosa. I hope you remember the last class.
Yes,
So even
yes,
after,
very important.
yeah, even after he's not passing the stool, you have to give us a call and we go and see the PR, and then we give the enema if required. That is what we usually do. This is the pattern. We don't give suppository on the initial day itself. First, we ask them to give the laxatives as prescribed. Slowly, we increase the dose if needed. And still, after keeping suppository, he is not passing the stool, then we give the enema. This is how the order is.
Exactly, that has to be followed. Many times they might not have had, we will say 2 times, 3 times, from single dose to BD, TDS has to be tried. It will work. Okay, we also have to be patient, and we have to tell them, encourage them to have some water in between. Sponges, like sponges you can give. All that you have to encourage, and many things they may not know. You will have to repeatedly tell. And then follow exactly what she has said. If A is not working, B is not working, C, then only you go to any. Like that you have to follow. Okay, if there's anything else, or otherwise we could wind up, I think, Sripriya, is that right?
Yes, ma'am. If no one else has got any more
Yes.
queries to be addressed. No more
Exactly.
But still, I'm sure there will be somebody with
Yes,
doubts
yes.
when you're practicing. You can definitely contact us or something like
Yes.
that when you need help. We have our groups there. If anybody is nearby our pallium, you can definitely come visit us. So all those
So that's all.
possibilities there.
And
Once you
see,
start
all of you should be able to keep in touch and help each other. See, you've
Yes, yes.
got 35 friends. That's what I would say. It's just not a platform. You're just saying, please don't be like that. Okay. Each one of you try to help each other and collectively come up well.
That is how we learn.
Be open, and that you've got 35 more friends. That's what I would say.
Thank you so much, Dr. Sangeetha, because we both work in the same setting, and I personally know that she has even skipped her lunch today in the run to serve people. And today's session was as interesting as possible because she is particularly interested in kids, in children, and maybe that is why she brought in the communication part again today. So thank you, Dr. Sangeetha, for your wonderful session. Hope everyone had got an enlightening session today as well. And thank you everyone for joining in and making this session as interactive as possible. Halfway through the 20 session series, I believe most of you have become more passionate towards what you are going to do in the field of palliative care after the course. So with that note, this is Sripriya, along with Dr. Radha Venkatesh and Dr. Sangeetha Suresh, signing off from the Tips Eco Hub. See you in the next session with another interesting topic and an eminent faculty. Till then, everyone, take care, be safe, happy. Bye-bye.
Thank you.
Thank you, one and all. Thank you, Sangeetha.